Stiak. Stiak, can you hear me?
Yes, I can hear you.
মাহবুব স্যার আর নিয়াজ স্যারকে কি কল করছো একটু?
আপনি একটু করেন,
I'm here.
Okay, sir. Thank you, sir.
So I think
Hi,
we can start.
Shamaresh,
Good evening.
Hi, hi.
Good to see you too, sir.
How's sir? How's sir doing?
Sir is doing fine, sir. He is enjoying holidays, not going to work, so he's just relaxing at home right now.
I'll give you a call one of these days.
He's decided to not go back to work at all. So,
Sir, it's 7:30. Can we start?
ইসাক মাহবুব স্যার আসছে?
না, আপনি একটা কল দেন, আমি একটু শুরু করি।
মাহবুব স্যার, আমি আমার ফোন সব বন্ধ করে রাখছি। নিয়াজ স্যারকে বলি। স্যার, নিয়াজ স্যার, আপনি কি একটু মাহবুব স্যার একটা কল দিবেন?
Right, I'm giving him a call. Problem হলো উনি তো আবার ফোন দিয়ে করে।
Okay, I think we should start.
Okay.
Shamaresh, Ashwin, Lee. Am I audible?
yeah, you're audible.
Yes.
Yes, you are.
Okay.
Bangladesh Eye Hospital and Institute is going to organize a series of webinars on ophthalmology. Ophthalmology Webinar 2020, this 19th and 26th of June, and 4th, 10th, and 17th of July 2020 at 7:30 p.m. Bangladesh Standard Time. Big names, great surgeons, passionate teachers, creative innovators, supportive peers of ophthalmology will be speaking on current trends, topics, managing difficult situations about their innovations. Join the webinar where you will have the chance to hear their thoughts, clarify your queries, and know what goes in their heads and minds.
Thank you, dear colleagues, for joining this webinar from different parts of the world. On behalf of Bangladesh Eye Hospital and Institute, I welcome you all. And before I start, I want to thank all the speakers and the panelists for accepting my invitation. And I also want to thank Dr. Shomoresh and Dr. Moon for coordinating with the faculties, and Aristovision for their technical support, especially Asif. And before we start the presentation, I just want to have a little introduction of our speakers. We have 5 speakers. All of them are great speakers and great surgeons. Dr. Lee Moon Wai, he is the director of LEC Eye Center, Malaysia. He is a fellowship trained VR surgeon, and he is chair of Malaysian Society of Cataract and Refractive Surgery. He has many international peer-reviewed publications, and those who have been in KL for the APS CRS, he did the live surgery there. Dr. Shomoresh, he is the consultant at Raghudeep Eye Hospital, Jaipur and Ahmedabad. And he has a knack for making ophthalmic films, and he has received many awards in ASCRS, ESCRS, and he has even got the grand prize in 2015 in the annual meeting, and he is an associate editor and reviewer of many ophthalmic journals. Dr. Ashwin, he is the cataract, cornea, refractive and anterior segment reconstruction, is the chairman board at Agarwal's Eye Hospital, executive director and chief of clinical service. And he is very much in association with the International Society of Refractive Surgeons. He has been doing all these nice webinars that we have been seeing, and he is also part of the American Academy of Ophthalmology's One Network. Dr. Ivo Ferreira Rios. He is born in Uruguay, now settled in Mexico. He's working as an assistant professor in Instituto de Ophthalmología, and he is the founder and CEO of Ophthalmo University. Those who have seen him, he does great webinars with many reputed ophthalmologists and teaching in a virtual simulated way, which he'll be talking today on. And I am going to be the moderator for today's webinar. I am basically a cataract, refractive, and glaucoma surgeon working as an assistant professor in Bangladesh Eye Hospital and Institute. This is going to be live streaming on YouTube and Facebook. So apart from Zoom, this can be also viewed there. And we have a question and answer box at the below of the screen. And I would request that to have this question and answer written over there, as all the question and answer will be answered after all our presentation are over. So I would now hand over to Dr. Shomoresh. I'll stop sharing my screen and request Shomoresh to start.
Thanks a lot, Ishtiaq. I hope I'm audible clearly.
Yeah, clearly.
Yes, you are.
So I wanted to wish a very good evening to all the people who have joined in esteemed faculty and, at Bangladesh Eye Hospital. I've always shared very fond memories of my brief visit to Bangladesh, and look forward to seeing you all in person very soon once again. Ishtiaq, you'll have to stop sharing your screen so that I can.
Oh, sorry. Yep.
No problem. No problem. Thank you. So as the lockdowns are opening up all over the world, and some cities are, like Ashwin just said, the cities locking down, while some cities like ours are just about to open. The question now arises as to when we start our cataract surgeries. For me, at least, I'm practicing in Jaipur, in a city in Rajasthan in India, and I'm only getting complicated cataracts, and mature cataracts and posterior polars are probably the only ones that are turning up at my door ever since the lockdowns have opened up. And it becomes very important, that more so now than ever before, that we deliver the right outcomes to these patients, because from having gone down to ground zero, back to square one and starting your practices again, every outcome matters very critically. So I'm going to discuss this on a pearl by pearl basis, just getting out of this. Sorry for this. Yeah, 1 second. Sorry for the glitch. Yeah, all right. So there are some pearls that we have learned in our institute over the years, and we all know that posterior polar cataract is a big nightmare for anybody, for a novice surgeon to most experienced surgeon. It can always be a problem. The first pearl that I want to share with all doctors, juniors and seniors, is that it's very important to avoid any rapid buildup of hydraulic pressure. Unlike any other normal cataract, a posterior polar is one where you don't want any tension inside the capsular bag. So what you don't want to do, you do not want to do the conventional hydrodelineation, which increases the fluid inside the bag, or a hydrodissection like this subcapsular hydrodissection that creates a fluid pocket between the capsular margins, capsular apparatus, and the lens itself, because it is going to inflate the bag, and a posterior polar cataract is an inherently weak cataract and it can give away. So this is the one thing that you do not want. The second pearl that I want to share is that we want to create a mechanical cushion, something between the posterior polar cataract and the nucleus, so that we are able to do a safe removal of the nucleus while keeping that cushion of the cortex around, so that the posterior capsule stays far away and does not trampoline anteriorly, because that's one thing we don't want to do. So this is how conventional hydrodelineation works. When you inject in a conventional hydrodelineation by making a small trench, you inadvertently cause some amount of hydrodissection because the fluid finds its way. And this hydrodissection can find its way into the posterior polar area. And if there is a weakness, it can give away. So you don't want to do a conventional hydrodelineation. Our team long back when I was still doing my MBBS published this technique from my mentor, Dr. Basavada, on inside out delineation, which reduced significantly the chances of ruptures during the intraoperative stage in the posterior polar cataract. So what is inside out delineation? In an inside out delineation, we first create a deep enough trench without having done any hydro maneuvers. And then using a specialized cannula, we inject in the wall of the nucleus, right at the heart of the nucleus, to be able to form a cleavage plane between the epinuclear cortex area and the hard nucleus area, so as to just divide the nucleus from the epinucleus cortex complex. I'll show you another clinical example of how this is done. So in this patient, we have already done a trenching, and then we use these special right and left hockey cannulas, as our team calls it, and we go into the depth of the nucleus and we inject very slowly and gently to find that golden ring of delineation of the nucleus, just enough to separate the nucleus from the epinucleus cortex area. And this, as I told you, is a very important thing, because since the epinucleus and the cortex has not been disturbed, it always stays adherent to the capsule, giving it a cushioning effect. Once you have done this, the third and one of the most important pearls that we tend to overlook most often is to avoid any forward bulge or any anterior movement of the posterior capsule and the epinucleus complex anteriorly. The moment it moves anteriorly, it gets stretched and it can give away. So how do you do that? You do that by using a closed chamber technique. How do you do a closed chamber technique? So suppose I've done my trenching, and before I do my right and left hockey hydrodelineation, I inject a dispersive viscoelastic. In this case, my preferred viscoelastic is Viscoat, because it is a truly dispersive viscoelastic, and it tamponades the entire capsule, entire nuclear complex posteriorly, and prevents any forward bulge. So never ever remove your instrument without doing an exchange using a viscoelastic, whatever you prefer on your table, but a preferred viscoelastic is a dispersive one. And once you've done that, the next important thing is to form a communication between the anterior and the posterior compartments of the anterior chamber. So like I said, once the nucleus has been delineated, the nucleus can be taken out easily. The sharp walls of the epinuclear margin over here can be used to tease out this epinucleus cortex complex using the appropriate parameters. So here I'm using a vacuum of only 150 and a flow rate of 14 to be able to pull out these fragments. And when I realize that I have formed enough cleavage in this area, I do a hydro maneuver using the same hockey to be able to remove this rest of the nucleus using a bimanual IA. So you have to do a hydro. You have to do a hydro dissection at some point in time. But once you have done a dissection enough for you to have a fluid that you know has passed off, it is unlikely that you will increase any pressure in the posterior compartment. Again, like I said, my preferred technique in all cataracts, but more so in a posterior polar cataract, is the use of a bimanual IA apparatus, because it keeps the chamber intact, because there's minimal to no leakage, and it gives me the flexibility of going and moving in all directions. Notice how I did a viscoelastic exchange before I changed my hands, and now I'm using both the hands possible to be able to take out as much nucleus as possible. And I mean epinucleus cortex as possible. And you will realize that if you go slow and you go quadrant by quadrant, inadvertently some wave would have passed, but it will cause a cleavage of that posterior polar area, most often without causing that area to deflect out. But the best pearl that I've learned over the years, over the last few years, is the use of a brilliant technology of femtosecond laser. Femtosecond is a great technology, but in a posterior polar cataract, in a mature cataract, it has a distinct advantage over other techniques. And why is that? Because we published this technique a few years back on femtodelineation, where we use femtodelineation to enhance the safety of these posterior polar cataracts. A femto, if you know, would make very, very sharp margins when it makes a cut. and you can avoid any hydro maneuver. Not even an inside-out delineation may be required to be able to take out and debulk this nucleus. So this is on an Alcon LensX platform, and notice what we are doing over here is we are not doing it's a modern density cataract, but we are only doing the rings. We are doing 1, 2, 3 rings. So we are going to cut the nucleus into 3 rings, and we are going to remove these rings one by one like an onion peel without using any hydro procedure whatsoever during the entire process. For those of you who have seen a femto know very well how fast it works. But this is how it looks on an animated scale. If you understand that these are the zones that have been cut off by the femto, the yellow being the innermost nucleus and then the outer softer nucleus, you can remove these zones one by one sequentially using moderate parameters and using no hydro procedures, and thereby debulking the nucleus in a sequential stepwise fashion. And once you've debulked the nucleus, you have enough space and there is unlikely to be any buildup of any hydraulic pressures inside, and therefore unlikely to be any rupture, or the chances of rupture go very, very low. Moving on to a clinical scenario with the same situation. So as I said, our ruptured rates published were 3.8%, just about 4%, which is a very, very good number. And over the years, these are all publications from our institute, where a conventional hydrodelineation showed us a rupture rate of 36% as early as 1999, and eventually moved out to our own technique of inside delineation. But the game changer was femtosecond, which completely changed the way we are looking at posterior polar cataracts now. So this is a case example. Notice how the rings have been cut. Now these margins are very sharply cut, and these things can be put up like biscuits. Notice how the first central ring comes out like a pure biscuit, and using very controlled parameters, a low bottle height of about 760 over here, a flow rate of about 18 to 20, and a vacuum that is appropriate to hold. Notice how you are able to pick up these nuclear fragments like an onion peel, one after the other, to be able to cause a smooth removal. Notice over here that the third layer of the nuclear epinuclear complex comes out very easily, because all you need to do is hold, use appropriate vacuum to be able to dissect out, and these can easily be flipped also using a chopper. Once the center of the nucleus has been debulked, the fear of nucleus falling down or the nuclear fragment going down in the posterior compartment are significantly gone. Once this is done, because the walls are again laser sharp for the epinucleus, one has to learn. This is a little bit of a learning curve, but once you are able to occlude using the low vacuum that you have in your machine and using parameters to the optimal scenario, you are able to create a cleavage plane now. This cleavage plane gives us a distinct advantage because now the fluid is already starting to pass between the posterior capsule. And again, like I said, do a viscoelastic exchange. Again, as I said, my preferred technique is a bimanual IA, very, very controlled parameters using a very low flow rate, because in a peristaltic pump, the flow rate governs how fast or how quick the surgery goes. And with this, you're able to, slowly tease out the entire fragment. And now once most of it is gone, then even if in this stage the posterior polar cataract ruptures, it's a salvageable situation. If it ruptured initially on with the nucleus in place, then it becomes very messy because the nuclear fragments can fall down and you might need to do a fragmentome to be able to take them out. It works on all different grades of cataract, soft and hard, equally effective. So this is a hard cataract. We use the same maneuver. The entire central nucleus pops out like a candy, and one can easily emulsify it. And then the rest of the procedure remains pretty much the same. Now, with the advent of this technique, we are now able to promise these patients a lot of advanced technology IOLs that we were not able to, or we were not very confident in doing earlier. So this is the same patient with the classical posterior polar cataract, and we had counseled this patient, and we have simply went ahead and implanted a full refractive restored lens in the patient's eye. And this is the second eye of the patient, and we are confident now doing this because we know that with our technique, more often than not, we'll be able to get away with it without causing any problems whatsoever, any compromise in anatomical integrity. Another important pearl last is you have to counsel the patient that no matter what technique you have, you can have the best femtosecond laser and the best intention, things can go wrong. And once things start going south, it becomes very difficult to explain to the patient if the patient has not been primed earlier. So I think one of the most important things we do is spend enough and more chair time before the surgery and tell the patient that if we are not able to put a lens in the eye, we will put a lens in a different position, or he might need more than one intervention to be able to make sure. Eventually the patient will see well, but the patient has to understand that this is how it works. But friends, it's very important to understand that a posterior polar cataract is not over until you're out of the theater. And just to show you a classical example, when I had my coffee ready and was stepping out, and I'm just hydro the final, main port incision, and look what happened. I have a rupture right at the end of surgery when I was finishing my last incision. So posterior polar cataract is not over until you go back to your, to your room and have land with a cup of coffee. You'll be ready that anything can go wrong. So my top pearls to summarize are: don't do a hydro procedure because you can avoid hydraulic pressure. Do an inside-out delineation and create a mechanical cushion of the epinucleus cortex complex. Do a viscoelastic exchange before you remove your instruments because you don't want things to go anterior. Create a communication by slow and controlled dissection so that the fluid has some time to pass. Femtodelineation is a game changer, and if you have an access to femtosecond technology, there is nothing like it. So please spend your time counseling the patient because it's very important for them to understand the problem that's there in their eye, and you're doing the best you can to fix. Thank you.
Thank you, Shamuresh. That was an excellent presentation, and I'm sure that this is going to help a lot of surgeons all over the world, whether they're young or, experienced. So now I invite Dr. Lee to share his screen and make his presentation. Please, Dr. Lee.
Hey, thank you. Can you hear me fine?
Yeah, fine. Can you share
Okay, I'm
your
just
screen?
going to move to my talk now. Okay. So thank you very much again to Ishtiaq for inviting me and having me be part of this great group here and this faculty. So I'm going to talk about capsular problems, not the end of the world. I think it's a rather broad topic, and really in this instant, it's just going to give a summary of some of the things that we will face as we are doing phacoemulsification. So my financial disclosure is as such. So these are things that we will face and encounter for every phaco surgeon because, phacoemulsification is our bread and butter. And these are moments when we have oops moments, you can call them. You don't want to say them out loud while you're operating, but these are times when we do face capsular problems and it's the bane of our existence. So what happens then? I think a lot of the time we become emotional, we get worried, and what you don't want to do is to move into a situation where you become panicked and start having that sinking feeling. So in my talk today, over the next 8 to 10 minutes, I hope to give an overview of some of the capsular challenges we face, be it anterior capsule or posterior capsule. I'm going to talk a little bit about vitreous management. It could be a whole other lecture on that, but just a summary of that. And of course, IOL options as we face capsular challenges during these times. So I think there have been a lot of reports in terms of papers that have talked about incidence of anterior capsule and posterior capsule problems, and these are some of the reported rates. And fortunately, they are low, but of course, on our learning curve, being from a trainee to a more accomplished surgeon, we will encounter, hopefully, a reduction of these rates of problems. But on the other hand, as we move to become so-called more accomplished, we end up doing more complicated cases. And again, there is also potential to face these problems more often, perhaps. So the video highlights what we call a hydrorupture, or you could call it a pupil snap. But a lot of the time, this happens, and it is something that we do face if you actually do hydrodissection this way, and you end up with a lot of fluid pressure, as you don't want to do in a posterior polar, as highlighted by Dr. Samresh just now. So commonly, anterior capsular tears occurs during CCC. I think it's reported most of the time before phaco as well. But more importantly, when you do get an anterior capsular tear, you get a high incidence of associated problems. You could have a wraparound, you get a PCR following. You end up with vitreous loss, drop nucleus, and some need secondary surgical procedures to either remove a drop nucleus or to put in a secondary lens. Poor refractive outcomes and a lot with permanent visual loss, perhaps due to cystoid macular edema or even retinal detachment. So we have to be aware in certain instances where this is not an exhaustive list, but particularly we face intumescent cataracts, we expect problems with the anterior capsule due to the intralenticular pressure. If there are pre-existing zonulisis, there will be difficulty in creating a CCC and problems associated with that. In shallow anterior chambers, glaucoma patients, perhaps, you will have these problems as well. Trauma cases, perhaps, with anterior capsular plaques, you anticipate problems there as well. And elastic capsules, perhaps in pediatric cataracts. So these are the cases where you do want to preempt or at least have a plan in place if you do run into problems with your anterior capsule. So this is well described, white cataracts, intumescent, and many techniques have been described, and we all know that we need to use viscoelastic and create a concavity and push all the cortical material to the side. People have talked about stroking it and aspirating fluid cortex, and there are many techniques. And this is important because this helps to reduce the intralenticular pressure. So there are also devices here as shown to actually help to create a circular CCC. As we know, in these instances, it can be difficult and challenging to do a good CCC. So this device here is a microsilicon pattern ring, which you can actually insert, and it sits on top of the capsule, and it creates a physical guide for you to tear and form around capsule. So it can be helpful, and you remove it after that. So just remember, you face a wide cataract, you have to be prepared to deal with the intralenticular pressure and aspirate the cortex. This is again a very well described technique by Brian Little. So this is not something new, but it's something that we do sometimes take for granted, those of us that do it without even thinking. But for those who are perhaps in the earlier part of your phaco career, you will find that if you have a rhexis that's running out, so in this instance, what you tend to do, you see that it's running out, you have to grab it near the edge and pull it tangentially towards the center. So you create centripetal force towards the center and bring that rhexis back. And that's how you can actually save the rhexis from running out to the equator or beyond. So this little technique is well described some 15 years ago by Brian Little, and it's an invaluable technique for us to have. Now, in some cases, this is traumatic cataract as I was doing, and the rhexis runs beyond the equator perhaps, or to the extent where you can't see well, and you're not sure whether you can exercise the little technique. You can sometimes go and start to try and do a little pull, and you see things not happening as they should, then you perhaps don't want to pull further. So in such instances, viscoelastic is always important to create space and visualize, improve visualization. And you come in from the other side. You can use micro scissors, cut the rhexis on the other side and try to complete the rhexis that way. So in this case, rather than pulling with the little technique, try to complete it from the other side. So you will see in this case, I managed to do that successfully. And at the end of the case, the rhexis is a bit eccentric, but it did not go around to the back. So this is a very good sign that has been well described by Dr. Ramprakash and group. I think the flat motility sign, I won't dwell on it in too long. This paper is already published for a few years, and he's talked about it several times. And I thank him and his group for teaching us about this important sign, because as we are operating and we see the anterior capsule, as you call it, flapping in the wind or everted, this tends to indicate that there's no extension of the anterior capsule to the posterior part, and you can perhaps safely continue with slow motion phaco. Now, if you have a flap that's perhaps inverted and not moving around that much, then there may be a posterior extension. It may not be safe to continue, and therefore perhaps an option to convert to a manual extraction of the nucleus may be a safer option. So the flat motility sign is something to keep in mind. Now, if in doubt, I think convert. There is no heroics in surgery. I think the most important part for us is to ensure that we are safe and do the correct thing and make sure that outcomes are good for our patient. So there is no shame really if in our hands we find that we need to convert. And in fact, there is paper talking about extra capsular cataract extraction, or perhaps in India and that part of the world, people are so well accomplished with the SICS technique, converting to a manual cataract extraction when you have problems is really not something that you should shy away from. Now, I'm switching gears a little bit to the posterior capsule now. I think this is a large paper that talked about the incidence of posterior capsule rupture, and not so much the incidence as well as to when it tends to happen. And it's usually during the phaco or INA part where we tend to get PCR. So again, there are certain instances. I think Dr. Samresh has very elegantly described techniques and pearls to actually manage posterior polar cataracts. So we have to beware in post-vitrectomy eyes, because you have perhaps floppy capsules and you got very deep, no vitreous support and very deep eyes. Previous intravitreal injections now, because our retinal colleagues are doing a lot of that, sometimes they may damage the posterior capsule as they're injecting. Traumatic cataracts are instances where you may have a deficient posterior capsule to start with. So early recognition is key. I think this comes with experience, and as we are trained, and during our training, we'll come across different scenarios. Perhaps our mentor will tell us, they might notice certain things, and you are good to actually pay attention to learn when you actually see potential problems along the way. So when you pick them up early, that's when you know how to intervene. So sudden deepening of the AC, problems with the pupil, difficulty with movement of the nucleus when it wasn't having problems before. All this are indications there may be problems with your posterior capsule. So when you do have a problem, sometimes this is a case where, one of those where at the end of the case, you get your post-occlusion surge and you get a little small puncture, a small little rent in your posterior capsule. If it's small enough and you can actually have a good way of converting this into a posterior capsular axis, it is actually a good technique to have because you can still safely put an intraocular lens into the bag. So this is a good technique to have to actually be able to save the situation. Now, vitreous management is something that we definitely have to pay attention to as we are dealing with capsular problems, because often case we will be faced with vitreous prolapse. So the principles of vitreous management is, of course, to make sure that we minimize intraoperative traction. So we know that vitreous actually is made of lots of collagen fibrils and there's attachments in different parts of the retina. We don't want to chase after vitreous, the nucleus pieces, and cause problems. So we don't want to cause vitreous traction. We want to prevent postoperative vitreous traction. So we make sure that we clear the vitreous properly. And we have to maintain a pressurized eye to prevent hypotony. So V is, of course, for victory, and V is for viscoelastic. Very important because OVDs, in this case, usually a dispersive type, will give us a lot of tamponade for the vitreous as well as visualization. With triamcinolone is equally important. And of course, vitrectomy. I think limbal versus pars plana is still a controversial topic because anterior segment surgeons are very familiar with limbal approach to doing vitrectomy. There is no right or wrong answer, but I believe there are more anterior segment surgeons moving towards doing a pars plana approach because it really does make sense. Pars plana may be a no-fly zone for a lot of people, but it doesn't really take longer. It's just a learning curve of learning how to put in a trocar or perhaps cutting down the conch and putting in and going in the pars plana. But really why it makes a lot of sense is because you're actually taking off or truncating the vitreous where it actually is coming from rather than coming from the front or the limbal approach and bringing more vitreous perhaps through the anterior posterior capsular tear and enlarging that tear. So there are lots of, there's been papers that talked about comparing the two and how do we do anterior vitrectomy. I think pars plana to me is the way forward, but limbal vitrectomy is also a preferred method at this point. So we should be able to use the same principles to do it both ways in the sense that you should have the highest possible cutting rate. With the anterior vitrectomy cutters we have now, we can go up to 4,000 cuts or perhaps even more. Lowest possible vacuum and a minimal infusion, just enough to maintain adequate volume and keep the eye pressurized. So these are the kind of settings you want. So there is no fixed setting. I think you need to be able to have a starting point, but you need to do enough to actually create a good setting for yourself. So this is just one of the pars plana vitrectomies that I've done. I think this is a 23 gauge trocar, showing the use of vitreous triamcinolone to highlight the vitreous. And as you see here, just to indicate how there is vitreous prolapsing to the wound. So as we are coming from the pars plana approach, you can see how you can remove all the vitreous from the back and not bringing it further forward into the anterior chamber. So you remove the vitreous as it is from where it's coming from, rather than bringing more forward. So finally, we're going to talk about IOL options, because when you have actually cleared all the vitreous and you've taken out all your nuclear pieces, now what do you do with the IOL? Can we still put in one? So the anterior chamber IOL is something that, we have all been, well, perhaps myself, been shying away from now in the recent years. It's not to say that it's a bad option, and there are a lot of people that are using good, have good outcomes with the anterior chamber IOLs. The difficulty is how many of us have good consignments of these in our OR to actually have as a backup, because they need to be sized properly, otherwise they won't sit well. They cause problems with the corneal endothelium, secondary glaucoma, etc. This is a newer artisan type kind of intraocular lens in the anterior chamber, but do we actually have this in consignment? No, because these have to be ordered, and most of the time it's going to end up with a secondary procedure and inconvenience to the patient. So a sulcus IOL and optic capture is something that's well described, and it's something that I just want to remind to perhaps our more junior colleagues, that is something that we need to have in our backup. Is definitely a 3-piece IOL. Putting this in the sulcus and subsequently optic capturing that in the anterior capsule will stabilize the IOL very well. So one thing to note is you do not want to put a single piece IOL, perhaps definitely not any of these square edge IOLs into the sulcus, because it can cause UGH syndrome. So you need a 3-piece if you're going to put it in the sulcus. So quick notes about how we all know Dr. Warren Hill. There is this chart that I have in my OR, which actually, because when we switch and put lenses in the sulcus, sometimes there's a change in the effective lens position, and there's a refractive outcomes may be impacted. So over here is just a quick table that I can refer to based on intraocular lens power that we planned and whether we're putting in the sulcus or in the back and whether we should switch downwards or upwards. As a principle, I think the lower power of your intraocular lens, the less you have to actually adjust. The higher the power of the intraocular lens that you plan for primarily, if you're going to change to a sulcus position, the bigger the change that you're going to have. So that's this table that to refer to. You can print it out from Dr. Hill's website. The other technique to have is a reverse optic capture. I think this is something that can be useful, but you need a small enough anterior capsule that's intact, where in this case, I have a ruptured PC where I had to put in the toric IOL, and what's important in this case to make sure that you put the haptics into the bag or what's remaining of the bag, but you're capturing the actual IOL anterior to the anterior capsule. So this is a reverse optic capture, and you can still use this technique. I think it's something that's not for everyone. It's not as easy to actually position the lens. And if in doubt, I think a sulcus 3-piece lens will suffice. But nowadays that we're doing more of these premium IOLs, we actually have problems sometimes when we can't put them in for our patients. Now, just a quick final word, nothing too much. We're talking about IOL fixation options. Scleral fixation has been well described, but I think we're moving away from sutures now. I think the Agarwal group first talked about the glued IOL. Of course, Gabor Sharioff talked about it many years ago. And I think we're moving towards intrascleral sutureless type fixation. And my go-to technique is the Yamane. I think a lot of people are doing that now. I love the Yamane because it gets me out of trouble if I do have a problem where I end up without having to have a sufficient support with the capsular bag. I don't have the CT Lucia Zeiss with me, so this is just a PMMA haptic 3-piece lens. This is the Alcon version. It works fine in my hands, and you can use the 30 gauge or even 27 gauge needles. And I think it's an elegant technique that gets me out of trouble, transconjunctival, with a learning curve, however. So all of these techniques have learning curves, but it's something that is good to have in your armamentarium to actually deal with capsular problems. So just coming to the end now, I think these moments, we are going to be faced with them. If you operate enough, we're going to have complications. But what we hope to do is actually be able to manage them well and take deep breaths and recognize the problems early, slow down just your thinking as well as your steps that you're going to take so that you come up with a good plan of action, manage the vitreous well, and put in an IOL or don't put in an IOL depending on your comfort level. So hopefully converting a real bad situation into something that you can manage well. So thank you very much again to Ishtiaq and to the esteemed faculty for the opportunity to talk to everyone here, and have a good evening. Thank you.
Thank you, Dr. Lee. That was a very elaborate and covering all the topics of how to manage the capsule problem anywhere in the anterior posterior. Now we have a good friend, Dr. Ivo from Mexico. I think it's morning over there and he is ready to go into OR. So Ivo, I think you can share your screen and we're ready to hear you.
Thank you very much. Can you hear me good?
Yeah, perfect.
Thank you so much for the invitation. It's an honor to be here, Ishtiake. And yes, you guys live in the future. I always joke, right? It's morning here. I'm starting my day. And I want to talk really fast about one of the topics that is the passion of my life. And I think it's not only about learning, but about to improve your outcomes as a surgeon. So virtual reality, it's here to stay, and it's here to help us to improve our outcomes. This is not very far away. Some of us still in many parts of the world are like learning cataract surgery like from a distance, right? Seeing the OR far away. It's very hard to, to have a good wet lab and how to practice. And right now we can see classes like this. Is basically, I think it's even more powerful than a class. It's an ecosystem. I call it an ecosystem, a surgical ecosystem. Imagine to learn with a colleague sitting next to you, watching every single step, with 15, 16 virtual simulators and a mentor walking around. I think this is the new way to teach. It's a new way to collaborate and to share knowledge in a very good way. And this is my humble belief, about how there is so many things we can learn, but without the human being in the OR. I think there is many skills that a cataract surgeon has that can be learned outside the OR. And there's a lot of evidence. I love that how Dr. Lee Moon Wai loves evidence as me. And as you can see there, there's this amazing research paper from Dr. John Ferris, who in a period of 6 years, as you're gonna see, and 265 surgeons, and 6 years, as I told you, look at this, 17,000 procedures. And what they did in the UK was to lower 38% the posterior capsular breaks in people in training by using virtual simulation. So this is a fact, and we should, we should learn a lot about it. As you can see there, sorry that is my screen. I would love you to see the PC rates with people before the simulator. I have no financial interest in the simulator and no support from them. And after the ICs, you can see how the PC rate came from 3.53 to 2.60. So imagine, Dr. Ferris was telling me the amount of resources they will saving each year by training the residents in a different way. As we have amazing surgeons here, maybe I get bored them if I talk about only teaching, but I do believe with the virtual simulator, as I'm gonna show you, you can become a better surgeon. You can have a repeatability of your movements and your outcomes. You can face complex cases, and also in the latest software, you can actually face complications. You always get an objective feedback from the machine, and that's, as we know, you cannot improve what you don't measure, so you're measuring your outcomes every time. There's also some research in the world about surgeons doing a warm-up before surgery. We like, you see a tennis player and he's warming up, you see a basketball player warming up before playing a game. Do we warm up? Is the same when we do the surgery in the first patient and the last patient of the day? I think there's a lot of things to talk about there. So I'm going to talk about three things. I always like to talk about three things, and how virtual reality can be very, very powerful. I'm going to talk about capsular rhexis. I'm going to talk about phaco-chop. I'm going to talk about anterior vitrectomy, and I'm going to repeat many amazing concepts that Dr. Lee Moon Wai said before, but in practice. As you can see there, I'm doing a capsular rhexis, and I want here, for example, you to understand how the machine works. The machine is a male head, and I have three instruments that every time they go into this plastic eye, you see in 3D.
Can
Yes.
you remove that color panel, the control panel? I think it's blocking the screen. We are all seeing a control panel over here, the color palette.
Oh, you're not seeing the video?
We are seeing the video, but it's covered by a
Covered with
color palette.
Color pencil palette.
Pencil palette, but I don't have anything. Let me.
Maybe it's behind this.
Oh, there you go.
yeah, this one.
Oh, so sorry, guys. But it was from the beginning?
Yes.
Don't worry,
Yeah,
go ahead.
Oh, man. Sorry.
Continue, Ivo. Thank you.
Sorry. So let's see. Let's put the volume down, and you can see the machine. You can see, I need to have a correct hand position. You need to see that I need to have correct ergonomics, and I'm seeing in 3D. So every time I'm doing a movement, I'm seeing in 3D. And I don't know if you see it, but that rhexis has a black line that I need to follow perfectly. So the machine will ask me and will evaluate me about the size, the roundness, and how well centered that is. So imagine to practice 100, 200, 500 capsular rhexis before, or when you want to get good, before put premium IOLs. So this will allow you to become a better surgeon. It's not only for learning, but to become better. In phaco-chop, we did a class a couple of days ago, and we found out that maybe 30 or 40% of phaco surgeons do phaco-chop. And I'm sure the guys who do chop here will know that it's such a good technique to do phaco-chop. It's so good to save ultrasound and to improve safety. So in this case, you're going to see an amazing video. You're going to see a side view of what I do when when I try to learn not only horizontal chop, but vertical chop, that there are two techniques that they need a lot of knowledge, and especially this, what I like to deconstruct. I'm gonna pause the video very quick so you guys understand. Let's show something better. So when you're doing chop, you have a red ball that only when you hold it with the correct vacuum will turn into green. Can you see also how people understand, you know, that you traction the sonula so much? So the ball is in green, and then I have a line with the second hand, you know, to do the correct movement. Okay, and when I'm doing the correct movement, the machine will evaluate me if I'm pushing up or down. So I'm traction the sonula. So imagine again for a cataract surgeon who is who is relaxed doing you know, divide and conquer, stop and chop, and he wants to train in faker chop. Here, by deconstructing that task, you can learn so much faster and with safer, with no you know, problems with a human being. Then again, look at that. Okay, I'm doing a holding, the ball turns from red to green, and then with the second hand, I'm doing the correct movement. If I go fast, here, people can also train how to do vertical chop. I think this is a very, very good tool to learn better. About anterior vitrectomy, I love this subject, and I was hearing what Dr. Lee Moon Wai was telling us about all these concepts, all about these principles we need to have every time we do an anterior vitrectomy. And listen to this one. This is a survey done in the UK to 350 surgeons who, after they finish residency, they don't even feel comfortable doing anterior vitrectomy. Remember the first research? They're doing great in their training. They don't get a chance to do many anterior vitrectomies. So what if we do an anterior vitrectomy, but in virtual simulation with all the concepts Dr. Lee Moon Wai was talking about, right? Look at this eye. You can see some cortex, you can see vitreous, you can see a posterior capsular break, and it's big. So what we do is, again, I'm going to show you in the last video how we can train surgeons with all those principles about an hermetic anterior chamber, the use of transinolone, how the vitreous behaves, because, you know, some surgeons, they're not used to how vitreous behaves in the anterior chamber, you know, manual training, settings. I think this is a revolution, a complete revolution. I have some students, sometimes they say, okay, I want to do anterior vitrectomy now. I know what to do, right? So it's a change even in the mindset. So I think simulation and virtual simulation came here to stay and to change the game. Look at the last slides I want to show with you. The machine will give you objective feedback. It will tell you how much vitreous was remaining in the anterior chamber. Did you go for the vitreous below the capsule? Is there remaining cortex? Did you pull vitreous from the posterior segment to the anterior segment? Very, very interesting metrics. At the moment, somebody's learning how to reason in an anterior vitrectomy. And this is one of the things I love the most. I said it before, I'm gonna say it again. You cannot improve what you don't measure. And why don't we measure our outcomes as surgeons? Look at this. This is what the machine will tell me about each student, how the performance is doing, and you know, and the machine will give them challenges. So as you can see in the bottom left, in the bottom right, sorry, you're gonna see how they improve step by step. Here you can see the challenges even more big, and here you can even compare how your student is doing against the world or the normal learning curve. So this is me, always with the virtual simulation. I'm drinking mate there because I'm from Uruguay. This is the drink we have all the time. Actually, I have one right here. This is like our coffee. So I really want to thank you guys for the invitation and what we did. If you really like this, we had 6 episodes. There was Dr. Susan Jacob. I'm sure you know her, doing INA, but we did capsular rhexis with Jeff PT, hydrodissection with Bruna Ventura from Brazil. So if you guys want to go how we did virtual live surgery, we did amazing things. That's the YouTube channel if you want to see more. And just to end, virtual simulation, it's not only with the virtual simulation, but if you play, this is with a good friend, Jackie Belts she's a good friend from Ashwin too, from Australia. She invited us a couple of years ago to go to an amazing course in Australia. And we were actually playing with virtual reality because it helps you in your decision making. So this is not only virtual reality with the simulator, but I advise all the students around there to play a lot with virtual reality. So then to end, experience is not about suffering, but about practicing. And we need to generate an ecosystem of surgeons as we're doing right now. So thank you very much, guys. Thank you for the time, and it's an honor to be here with you.
Thank you, Ivo. That was fantastic. I wish we had this sort of things when we learned, and even if we have it, we can, the students are going to be benefited very much. So it's to Ashwin. I think he is in a hurry. He has to join another one, but we are all ready to hear from you, Ashwin. Sure. I think you can share, and he's going to be talking on capsular plastic. Yeah, we can see.
You guys can see. Okay. So I'm not just going to talk about pupilloplasty because I think iris repair overall has seen an uptrend in terms of, I'm just going to pause. I think for all the youngsters and for people who are experienced as well, I think the most important point is there's no better time than now to actually learn pupilloplasty, because there are so many things in our armamentarium that we can use to deploy at different points of time to correct that pupil repair. It's not just the pupil. The pupil works because there's a attachment called as the iris root, and that iris root is also very important because that gives the counter traction to forming the pupil. And so an iridodialysis and pupil repair is a complete different course altogether, and I think that itself is going to speak volumes. I'm going to take you through two basic procedures that are my favorites, one in pupilloplasty and the second in iridodialysis, and then I'll show you how we can combine these procedures in a real-time scenario. So let's just understand first what we're doing in a pupilloplasty. I've broken this down as much as we could. So if you see the iris, there's always a proximal iris, and then there's a distal iris. There's a proximal incision and a distal one. So this is the distal incision. Can you guys see it? Is it clear? Is it visible for you guys? I just want to know. I want to make sure. All right. So here's the proximal incision. This is the proximal iris. Pass a 26 gauge needle through the distal incision and iris. Railroad that 10-O-proline or a 9-O-proline suture all the way out. So here's what I'm doing. I'm railroading that through a 26 gauge and a 10-O-proline polypropylene suture. Now let's break this down. This suture trail is very important to understand. There are 5 parts to this suture trail. There's one external to proximal incision to proximal iris to distal iris to distal incision, and the last. Yes.
Is this a video? I think it's just stuck.
Yeah, it's a video.
It's stuck. It's not moving.
Okay. Yeah, so that's what I figured. That's why I asked. Okay. Yeah. I'm going to go back.
Now, I think yes.
Is it better?
Yeah, it's perfect now.
Okay, I'm just going to leave it at this. So this is the suture trail. I'll just break it down again. So you have external to proximal incision to proximal iris to distal iris to distal incision. That's part 4. And part 5 is distal incision to the external. Now, why is this important? Everybody asks me, which is the part that you take the loop from? I take the loop from part 2 of this suture trail. Once I've taken this loop, I bring it out of the distal incision. That is the incision on the opposite side where I went in with my 26 gauge needle. Once this loop is outside, I cut part 5. I am cutting part 5. That is the free end of the suture. The free end is completely cut, and I throw this 4 times into that loop. That's it. 1, 2, 3, 4. And that's about it. And I pull part 1 and part 5 apart. This is all I do for my pupilloplasty. And I know how confusing it has been all these years when we used to do 3, 2, 1, 3, 2. What are these guys talking? So what it basically happens is a helical pattern is formed at that knot. And this helical pattern basically ties the iris suture tissue all down in size. Now, you'll ask me one question: is that enough? Why is that enough? How is that staying? Now, the reason it's staying is because 4 throws are more than enough for a knot to stay in its place. But if you do 5, you can do 5. There's no harm in it. But 3 does not stay. Okay, I hope that was clear. And now that is exactly what I do for all pupilloplasties now. I don't do any of the other techniques. There's Seepsers, there's Mechanels and others. I don't do any of them. This is a procedure called as the sewing machine technique, which I use for my iridodialysis repair. If you see this case, what happened is the surgeon had a phaco wound. Using the phaco probe, he dragged the iris tissue inside. Now that caused a iridodialysis on that end. So now, first up, never use that same side of the wound for going and correcting the phaco part, because it will only cause more and more iris to prolapse out. So I'm making a ridge on that side of the iridodialysis. Using an iris hook, I basically am holding that iris back because it will otherwise come into my phaco wound. Once I've finished, and just in interest of time, I'm not going to show you too much of the phaco part of it because the bag, everything is perfectly fine. I just had to complete that phaco part. Once that's done, I've placed my lens. Now I start to attack the iridodialysis repair. Now the iridodialysis repair here, first I'm pushing some viscoelastic inside the eye. Opposite side, I'm making a entry, making sure that I can see the iris root that I want to use. Now, what is my apparatus here? Just see this apparatus. It's a 26 gauge needle and a ninoprolene suture. Before I have entered the eye, I am passing that ninoprolene suture into the 26 gauge needle and pass it in such a way that I pass it all the way through, even the thread, all the way through till the end, and I pull. That's my apparatus. So I'm not using the ninoprolene suture. Instead, I'm using the 26 gauge needle with the thread of the ninoprolene suture. This apparatus now I'm using to go through my incision, through the iris root, through the ridge which I made. Once I have made that one entry, I come out. I don't come out of the eye. I go to another site and make a loop exactly like what I'm showing you, and now come out. So once I've made these 3 passes into the iris root, this technique, by the way, was discovered by Ravi Kumar from Bangalore, and I think credit has to be given to him. Now attach 1 and 2 in the same way that you would an external suture. Nothing changes. 3, 2, 1. You want to do 3, 1, 1. That's fine. It's up to you. And that's pretty much it. So again, showing you now in real time, going through the iris root, come out of the ridge, making sure that the free end is here. Now that's a free end, completely free end of the suture. Taking another side. Now this is a loop. Hold the loop, come back in and go into the scleral ridge at a third site. Once these 2 loops are there, now this is how it looks on table. Cut in between the loops is one option. There are other ways to get past this, but my best method is intermittent sutures. So I like to use intermittent sutures in these cases. The free end of one and the free end of the other is now tied together. Similarly, the free end of 3 and 4 are tied together, and that brings the whole iris back to its place where it should be. This is called the sewing machine technique. It holds that iris back. Now you see that little edge. Now, why am I talking about combination procedures? The reason I'm talking about combination procedures, let me explain to you in the next case. Here's the sewing machine technique. I'll close that sewing machine technique and we'll move to okay. So here's a case which is a patient came from Iraq actually. And is my screen visible to you all?
Visible. Ashwin, we can see it clearly.
Can you guys see my screen?
Yeah,
Yeah.
perfectly.
Perfectly.
Okay, I guess you are. Is it visible?
Yeah,
Yeah,
Ashwin.
Ashwin,
Yes.
we can hear, we
No,
can
I
see you.
guess you guys are all muted.
Yeah, we can see you.
Okay,
Yes,
I'm
no problem.
continuing. So in this case, this patient came from the knifing injury from Iraq. So first up, what I have to do is leave that primary repair. I'm not correcting the cornea in this case. I'm first placing my lens. Once I've placed my lens using the glue dial technique, and for purposes of time, I'm not going to be talking much about that. I've done my glue dial technique here. Here, now I start attacking the iris tissue. First up, I need counter traction before I can correct the pupil. Here, I need iris root repair. So I'm doing a different technique here called as hang back. The hang back technique is basically using the iris root, a double arm, straight double arm suture just passed through at different sites out of the eye. And once you get that loop, it all just holds it back. It's a very simple procedure, can be done by anybody. I also have to do another iris root repair inferiorly to ensure that this is held in place. Now do my single pass fourth row to ensure that the pupil size comes down. And this is why this has completely changed the visual outcome for patients. Now, is this enough? I felt no, so I went ahead and did another one, which, by the way, my heart was in my mouth when I was doing this, because one little lapse here and it could go south where the whole thing can just cheese wire out, and I probably will be stuck with no iris in that site, which is fine, but I have to try. But the patient eventually had a wonderful outcome, had a 624, and this is the first week post-operative patient, and 3 weeks post-op I was a 624 from a PL positive eye. So those are the advantages of a combination procedure. Ishtake, thank you for having me, but how much time do I have left? Can
You
you,
can continue.
Yeah, Ashwin.
in that case, I'll continue or stop?
You can continue, Ashwin.
I'm unable to hear you.
Yeah, we can hear you very loud.
Yeah, please continue, Ashwin. I think Ishtiaq said.
Yeah. Ashwin, can you hear me?
Yeah. Can you hear us?
Yes, I can hear you. I think.
Can you guys
Ashwin,
see me, hear me?
yeah, we can see you.
We can see and hear you.
Okay, I'll just continue in that case. So this is a combination procedure done for a corneal tear, sphincter tear, iris stromal tear, and iridodialysis. Traumatic, both anterior and posterior capsule are broken. So we have a really complex scenario here. After checking, I knew that this capsule was already torn, so I actually had to ensure that I at least made some form of entry to make a rexis over here. Partial rexis may not be complete. Ensured that this was a 27-year-old, so the lens came out pretty easily. I knew that there was a vitreous in the AC. Because of the vitreous being in the AC, I always make sure that I do a proper vitrectomy in these cases. Anterior, I always look back for posterior whenever the posterior capsule is broken beforehand. Ensure that an IOL is injected in place. We're using the glue dial technique, put some triamcinolone, and now come to start treating the iris repair or the complete iris repair. This is why a reconstruction of the iris is very important. So let's see what happens here. There's a pupil repair required. There's an iridodialysis, and there is a stromal tear as well. So it's completely torn out. So first things, I have to treat the root of this iris. The root has to combine to come together first. And so the first thing I'm doing is I am doing a single pass fourth row at the root, not at the level of pupil, but at the level of the root. So once you do that, you ensure that you have brought the roots together. At least you have the root all together now. Now what you do is, because I have a flap of the glued IOL here, again, reassess first, reassess this case again. Now you have more than 180 degrees. And so what I started to do is, using a hang back technique, I pull that iris tissue back through under the flap using a double arm Prolene suture. And there's the second arm, which goes through the iris root. There's the loop. It pulls the complete iris back. And once this is, now this you don't need to bury because you have a flap that covers it, but this edge of that optic is really annoying. And I really don't like that. Plus, that is the one game changer when it comes to visual outcome. So this leaflet of this flapping leaves of the pupil can be repeated with single pass fourth row so as to complete this procedure. And you can see here, once I've done that, you can see the pupil come down, maybe not a complete round or a circle, but definitely better than what we had from the beginning, number one. And this is day 1 post-op of the same case. This is day 3 of the same. And this is 20/30 vision, 3 weeks post-op. So this is the before and after of this patient. I wanted to thank Ishtaki for having me on this course, but I'm really not sure why I'm not able to hear you guys.
Yeah, we can hear you very much. Ashwin.
I guess you guys are hearing me, but
yeah, perfect. Ashwin, that was an excellent presentation.
Sign back and I'm going to sign out and come back again. Is that okay?
Certainly, yes.
Yeah, I think I'm going to just do that.
So it's my turn now. I'm going to start. Am I visible?
Yes.
Yes, you are.
Okay, so I'm going to talk on iridodialysis management. I think Ashwin has said a couple of things and he has shown the sewing machine technique, so I'm not going to go over there. So blunt trauma is the cause of iridodialysis, which can be on varying extent from little to large, as we can see here. And the symptoms also varies depending on this. And sometimes the surgeons, while we are doing surgery, we can also cause iridodialysis. These are sometimes associated with other traumatic complications. And symptoms varies from photophobia, double vision, glare, and cosmetic problems. This is a video which showed that this was a trainee have done a wonderful phaco, and at the end the iris was coming out. So while trying to get it in from the side port, the surgeon has created a iridodialysis here. So it's not the only blunt trauma that can cause. Sometimes we are also capable of making this. So the techniques, as Ashwin has already mentioned, that McConnell hangback technique, swing machine technique, excellently shown by Ashwin, or double flanged polypropylene suture. There are a lot. And I think that all works very well. And we should know and learn how to do all of these and find out which one works well in our hand. A couple of things that I am going to be showing here is that what are the things that matters when we are doing the surgery. I don't know that if we can try these sort of things on a simulator, we'll learn from Evo later on.
Sadly, we don't have that.
Okay, so hopefully we'll get it. So whether to make a scleral groove or pocket, or we don't need any pocket. Do this iridodialysis repair. Whether we want to go ab external or ab internal. That means we want to go from outside in or bring the sutures from the anterior chamber to out. Supporting the iris tissue with a forceps, though it looks very good, but sometimes ergonomically it's very difficult. And we can also support the iris tissue with a 26 needle while we are piercing it. And what to use to pierce the tissue, the suture needle or the 26 cannula. This also varies and has cons. So what type of needle are we going to use on a 10-0 Prolene, the STC6 or CIF? So I'm going to be focusing on these sort of things. This is a traumatic dialysis, and we can see that the dialysis was nearly 2 hours with a complicated cataract, which was white again. And I'm going to skip forward the cataract part. This was a soft one, and hence there was some zonular dehiscence. So put a CTR, put the IOL, did a peritomy at the place where there was iridodialysis. After cautery, marked 1.5 millimeter, and then made a groove. And with the STC6 needle, straight needle, went ab externo, gave support from the other side, entered a 26 needle and railroaded it. So we can make a side port for bringing the needle here. And the straight needle easily goes outside, and again we re-enter the anterior chamber, enter the eye with a 26 needle in the groove that we have already created, and support the iris tissue with that needle. So this gives us leverage that we don't have to use a forceps or micro forceps and again transfer it to the needle. Bring those two sutures. And as this was a small iridodialysis, just one suture was enough. And later on, it was buried in the groove. And I always do a translational assisted vitrectomy. And sometimes it surprises that how much vitreous is there. So this case was over. This was a little bit larger dialysis, and there was vitreous in the anterior chamber. So before starting anything, I did a TA assisted vitrectomy. And as the iris was nearly in the center, I used the iris hook to reposit it, and then started rhexis with the cystitome. But I could see that the lens was moving too much, so used forceps to complete it. And as it was a soft lens, removed it with nearly vacuum, and did IA in the intact zonular area. And as we can see that there was zonular dehiscence in the vitreous collapsed area. Gave a CTR to give a support, and if the subluxation was more, we had to use a segment hook. And as this was rolled for nearly 2 or 3 months, we had to unroll it. So give viscoelastics below it, and sometimes we have to use 2 microforceps to straighten that unrolled part. And as in case of this sort of big dialysis, I like to mark that where I want my sutures. After unrolling, I have here used a microforceps to grip the iris, and without any groove here, I entered the eye with a 26 cannula nearly 1.5 millimeters from the limbus, just anterior to the scleral spur. Brought that needle. And here I want to just emphasize that we should not tighten or lock the sutures, rather just put it back there or give a slip knot just once so that we can tighten it later. And then this time I went ab externo with the help of the forceps, pierce the iris tissue. We have to be very crucial that we don't hold too much of the iris tissue, because then when we will pull, there will be eccentric pupil. And again, we can see that I have given a slip knot rather than finally giving the knot. So passing in the same technique. And here what I do is when I am going superior and inferior, I bend the straight needle. That helps to pass it. If it is straight, it sometimes creates problem in the eyelids. So bring it back, suture it again. And in the similar way, I'm just going to go fast forward, finish the third one. So this was nearly 180 degree of iridodialysis, and with 3 sutures, I could manage it, and the iris was back to nearly its normal position here. And once all the sutures were there, I finally tightened them, and with the Sinski hook, just make a little impression, and then we can bury the knot. So it's not essential that we have to make a groove, but we should not make it issue out of it. If we need to make a groove, we can make it, but without groove, this can be also done. And this was the case after it. So the before the surgery and after the surgery. So at the end, I want to say that we want to do all this procedure in a closed chamber, address the vitreous if there is there, unroll the tissue, and we should not take too much of the iris tissue. Otherwise, if we tighten it, we may cause correctopia. So thank you all for the patience hearing. And now I want to introduce our panel, bringing the panels for the question and answer sessions. We have a great panel here. I'm going to introduce them: Dr. Mahbub Rahman Chaudhary, Dr. Abdul Rakib Tushar, Dr. Niaz Abdul Rahman, and Dr. Sarwar Alam. Dr. Mahbub Rahman Chaudhary, he is the chairman of Bangladesh Eye Hospital and Institute, and he has pioneered phacoemulsification in Bangladesh. He is the past president of Bangladesh Society of Cataract and Refractive Surgeon, and he has brought phaco development program in Bangladesh. He is running it so nicely, and we have had a lot of trainees, nearly 100 from all over the world, from Germany, Nigeria, Malaysia, and many different parts of the world. And he has created a lot of excellent surgeons in our country. Dr. Niaz Abdul Rahman, he has pioneered beer surgery in Bangladesh, and is the managing director of Bangladesh Eye Hospital and Institute. He is the current president of Vitreoretinal Society. And Dr. Sarwar Alam, he is the professor at Islamia Eye Hospital and Institute in the Department of Corneal and Anterior Segment. He also looks after the educational department of that institute, and he has been affiliated with cataract and cornea training from 1996. And over the years, we have learned a lot from him. Dr. Muhammad Abdul Rakib Tushar, he is working as an associate professor in Ibrahim Medical College and Bardem Hospital. He's also a consultant to Harun Eye Hospital. He is the vice president of Bangladesh Society of Cataract and Refractive Surgeon, and he loves to teach, and he has also produced many phacosurgeons. So I would now stop sharing my screen and bring in the panelist for the question and answer session. So I think Ashwin has also joined. I would like to request the panel that he has another commitment. So any questions or comments regarding his presentation, can we make it first? I would request Dr. Mahbub Rahman Chaudhary to start.
Yes, can you hear me?
Yes, perfectly.
Yeah, good. Dr. Ishtiaq, I want to thank you for wonderful arranging this wonderful webinar, and all the speakers has been excellent, and it was a great honor to see the technique they have used, and it is Dr. Ivo's presentation. It was an eye-opener for us, and we'll be looking forward for similar simulator if we can use in our training program. Oshin, you have been a wonderful surgeon, and we have seen you in different conferences also. And what would be the easiest way for our beginners, for our new surgeon, to learn the procedure that you have shown, the pupilloplasty, and would you recommend an easy way of how they can go ahead and learn step by step the procedure that you have shown? Dr. Ashwin, please.
Yeah, I think that's a that's a right question, honestly speaking, because all of these procedures, whichever way you're doing iris repair in any form and any procedure that you're using, you actually have to understand that iris tissue it's all about tissue handling in these iris repair, because you're not actually very close to the iris. You're using items outside the eye, and a small 0.1 millimeter movement actually swings that suture more than 1 millimeter. And this is a very big step when you're doing iris repair. So what I would suggest is, do not do them in phakic eyes first. If you have a phakic eye, never try this out initially. Second, you always want to have, I would rather have saline or BSS inside the eye than have viscoelastic, because that gives the right movement inside the eye, number one. So the biggest point, what I would say in iris repair is, try a technique which you can replicate on a dummy eye outside, because what you're going to do on a dummy eye outside is what is going to happen. Actually, much worse is going to happen inside the eye. In a dummy eye, you're a little more relaxed and you're not thinking of so much of pulling and yanking. And that will happen during these first few maneuvers. So what I would definitely suggest is try not to do the extreme cases first, just small steps post finishing your phacoemulsification. If you have those cases where there's a slight dilatation on one side or a slight repair, which because of some injury that the patient had. So select your cases as well.
Thank you, Dr. Ashwin. Thank you so much. Dr. Shamresh, it's always pleasure and honor to listen to your presentation. And we closely follow you in different conferences. And here I would like to see what is the difference between the conventional hydrodelineation that you do and the inside-out hydrodelineation that you have shown in your technique. Would you elaborate this a bit, please, Dr. Shamresh? Are you there? Can you hear me?
Yes, sir. Yeah, I can hear you. I hope you can hear me, sir.
Yes, sir.
Yeah.
Thank you.
Thanks, sir. It is great to see you, sir. It's great to see you, and it's a great honor to be present in front of you once again.
And I'm looking forward to your visit to Bangladesh. Please do come over.
Definitely, sir. So actually, it's a great question, because sometimes it can be a very difficult concept to understand the difference between a conventional hydrodelineation and an inside out. So in the conventional hydrodelineation, once we finish our rexus, we go and bury our our irrigation straight into the nucleus, and we inject over there. But because we are not in the depth of the nucleus, some of the fluid finds its way up back into the nucleus, from the nucleus, and goes and causes an inadvertent hydrodelineation and a dissection as well. So that dissection is a problem, because until you're delineating, it's fine. But the moment the fluid starts to find its way between the anterior capsule and the lens substance is when the fluid can go posteriorly. On another hand, if you don't do any hydro and do a trenching first, bury your irrigation cannula at the depth of the trench and inject, you are not going to find that cleavage plane between the capsule and the lens material, and the fluid will only delineate and form a golden ring of the nucleus. So the idea is to debulk the nucleus, because PCR can happen at any stage in a posterior polar cataract. But once you have your bulk of your nucleus out, is when you can safely say that at least you will not need a bigger VR procedure to be able to take out that nucleus. So conventional hydrodelineation leads to dissection inadvertently sometimes.
Thank you. Dr. Shamresh, one more thing. You have been doing laser-assisted phacosurgery, and you have shown very decently, elegantly, how to deal with posterior polar cataract with this Lensex machine. So conventional, when we are doing Lensex, we are keeping about 800 to 700 to 800 micron of tissue. Laser will not penetrate beneath that. In case of posterior capsular cataract, posterior polar cataract, what should be the margin the safety margin that we would recommend when we are doing Lensex?
So 700-800 is a very good margin. I think the same margin applies to posterior polar cataract as well, because only that much of cushion is required between the posterior capsule and our phaco plane, so that it is always there protecting the posterior capsule. And the mechanical effect of that is always protecting the posterior capsule from coming up. So 700-800 margin is a good enough margin.
Thank you. Thank you so much. Now I'm handing over to Dr. Niaz Abdul Rahman, our respected panelist. Dr. Niaz, over to you.
Unmute, sir. I think Dr. Ashwin has to leave. Before he leaves, I just have a couple of two questions to him.
Yeah.
First thing is that what is the ideal size that you look for, and how do you center it? I mean, it's under periorbital block. So how do you center by using the Purkinje image?
So you use only Purkinje image 1. Don't use any of the others. Number 1, as much as possible, keep the head centered to the microscope. I mean, the eye centered to the microscope, not the head. I mean, you can put the nose, but that'll actually throw you off a bit. So actually tilt the head a little bit towards and make sure that it's in line with that. That's one. The second trick that you can use is an ink dot. To mark the pupil, the center of the cornea beforehand. So beforehand, if you mark, you'll always realize. So those are few tricks that we've used at least, and I think they've been exceptional. But the advantage over here is if you're not going down below 2 millimeters, if you're going to stick to 2 millimeters, you are pretty much in that space where you have a margin for error. So you really don't want to think too much on that angle. At the same time, you want to measure, keep your this thing, and make sure that if you want to get it circle, there are two tricks if you want to get it circle. And this I learned after I made these videos. I think it's very, very neat trick. You use an electrodiathermy, endodiathermy on the iris, which is on the other side. So let's say it's peaked like this. So all you really need to do is do the endodiathermy here. It will pull up the iris here. Just a low cautery endodiathermy, it will pull the iris up. It contracts the iris tissue, and that really makes the pupil completely round. And wherever you need, you can do it. And so that's a beautiful trick which has absolutely changed the way to get circular round pupils.
Ishtiaq, we have a two question for Dr. Oshin because he is leaving. The one question from Ernest Ejek, why the iris is do not bleed when you pass through it. The second question from our Professor Nazrul Islam sir, sometime after keratoplasty results in a dilated pupil unresponsive to miotics, secondary to ischemic necrosis of the iris sphincter muscle. Can we do pupiloplasty in this case? What is the preferred method?
So I think the first question, why does it not bleed? I think they can bleed. So there's no doubt about it, they can bleed. But having said that, I have never aborted a case in iris repair till date for bleeding issues. I've never aborted. It happens more at the time when you're doing iridodialysis repair, not so much when you're doing pupil repair. And this is a known fact, and you can check it out for any of this thing. There's a chance that it can bleed, but it'll stop for sure. And that this is something that is given. The second question is very interesting, and I think it's, I'm glad you asked that question. 100% pupiloplasty can be done. I think it has to be done in all keratoplasties. So there is the hypothesis of, I'm not sure if it's a hypothesis or what, but the iris actually goes and forms a PAS eventually in most long-standing keratoplasties. And this can easily be avoided if you're physically, mechanically stretching that iris to bring it and create a compartment rather than allowing, I mean, I've seen people use mydriatics or drops, pilocarpine and stuff like that to kind of reduce. It will never happen. It cannot happen because eventually light's going to come, light's going to take over, and it is going to dilate. And that dilatation effect is just going to allow it to go closer and closer to the cornea, which is needing some form of nutrition. And it's probably that which is tending that iris towards that side. So physiologically, I'm not sure what the answer is, but what we are seeing is the minute you bring it down, three things change. One is the neovascularization goes away. The second is intraocular pressure comes down back to normal size because you're physically actually opening up those angles.
Right.
And third is you are going to get clear corneas because all that IOP rise does is damages your cornea and creates a havoc for your endothelium. So these are major three changes that I've seen happen the minute we started doing pupiloplasty.
Thank you, Ashwin. Thank you very much. Ivo, are you there? Dr. Niaz, I think Ivo has to go into the OR, so we'll have his question now. Dr. Ivo.
He's not in video.
Okay, I think he's preparing
He just stepped out. I think he just stepped out.
Yeah. So, Dr.
We
Niaz.
can hand over to Dr. Niaz. Yes.
Thank you. Thank you very much. Ishtiaq, this was a wonderful session. All the faculty, your presentations were amazing. I'm really glad that we had this session. Now, well, Dr. Chaudhary addressed Shamaresh. Well, I just want to say that, you know.
Dr. Ivo is here.
Sorry, guys, I'm here, but
He's all right. Want to ask his question or shall I continue?
Yeah.
Yes, sure. I have time for a quick question.
Okay. So, Rocky?
Yeah, the question for Dr. Ivo, the main question, lot of question for Dr. Ivo is the system can be available in Bangladesh in any way, like whole systems or anything, and we need to establish that things because like a developing country of Bangladesh, we need a lot of factor surgeons to be developed, and we need that things. And what is your suggestion to get these things, virtual things?
That's a very good question. And remember, I live in Mexico City. I came from Uruguay. These are not places that we have a lot of cash, to. But the thing is, if you go back to Dr. Ferris' research paper, he has data, so he could talk to the government and convince them that they save so much money actually with this machine, because students can have a better learning curve and you have less complications. So if you really think the big picture, this machine that can be very expensive in the beginning is not that expensive, because it allows you to save a lot of resources, and especially to protect, to have better safety for patients. So yes, the money issue, it's important. But the second thing I would like to say is that machine by itself, it's not as powerful if it's surrounded with a good methodology and a new way to teach young ophthalmologists.
Okay. And my question to you, the machine and the software you develop to learn the virtually, is it separate or this is integrated?
The what, sorry?
The machine and the software you developed to learn.
Well, that's more about the business side. I know a little bit about it, but if you buy the hardware, I don't know if I'm mistaken, you have the software for 3 or 4 years or something like that. It will keep upgrading. For example, the anterior vitrectomy module is very new, but it's a game changer, because we didn't have the chance to teach, right, Dr. Lee Munya? I'm sure you love this software to teach all the principles you were talking about. It's not the same as what showing a couple of slides, but to actually people be doing hands-on activities on it. So yes, I think you need to be upgrading the software, but it's not like year by year. I think it's every 3 years.
Okay, thank you. Can I hand over to the mic to the Dr. Niyaz Abdul Rahman, sir?
Thank you, Tushar. So, Dr. Ivo, it was wonderful to see this machine. I had an opportunity in some conferences to sit on and do virtual surgery, especially retina surgery, posterior segment surgery. But it was not, I'd never felt real in that sense that it was not giving me a good tactile feedback. That was what I was missing when I was doing the vitrectomies. And but over here, the way you showed the phaco, maybe, I don't know, when you do the rexes, you get a better feel of it. I'm not quite sure, but it did look very interesting, and I'm sure it will help. The kind of phaco programs that we are doing, Dr. Chaudhry's phaco development program that we are all part of, I think this kind of machine would really help us for that program, because we've already produced over 100 phaco surgeons who are doing good phaco, and this would cut down the cost in the sense that they don't have to operate on real patients. So that was a very big eye opener for us. I think we'll look into it and see whether this is a possibility to get it for the program. Thank you very much for showing this to us. Wonderful.
No, you're welcome. Just a quick comment on that. It's a very fair question. And when we talk about simulation, we talk about fidelity, how similar to real life it is. And there is some parts that they're not, actually completely real, not realistic. Sorry, that's the word. But then again, when you think about what you learn about motor skills, about hand position, about how movements in the eye, about the decision making, the problem solving, and you have all that. About the feedback, one of the amazing things that this machine has is it will always make you, and will penalize you if you don't have a centered eye, a red reflex. And by doing that, you're actually, sensing everything that you're doing in the capsular axis, in the anterior vitrectomy. You're welcome to join us and try it. I'm sure you're going to love it.
Yeah. Thank you.
Thank you. Thank you.
Thank you very much for the invitation. It was a real honor. Ishtiake, thank you so much. You're so wonderful for having me here. I would love to join you guys in the future, okay?
That will
Thank
improve
you.
the condition where it gets
Thank you.
normal.
Thank you,
Bye-bye.
Eva. I have a small question to Dr. Lee. You see, for example, the cases that eventually needed a vitrectomy. Now, you started doing the phaco with a topical. And then when you do the vitrectomy, like if I'm a retina surgeon, if I need to do a vitrectomy, if something goes wrong, I would always prefer to do a pars plana approach rather than an anterior approach, because I think that's a much better approach. But the thing is, we have started off with topical. Now people ask about the anesthesia. What do you do? What do you do once you're decided to do a pars plana approach?
Well, I think, well, I'm a retinal surgeon as well. That's why I'm biased towards the pars plana. But I think we encounter this situation. So when I have that situation, I will always top up with the subtenons, because the eye is opened. You know, sometimes if I normally give a peribulbar if I plan to actually do a complicated case, but if you started off topical and you have to convert to do some pars plana work, I think it's easy enough to do a subtenons anesthesia. So just open up the conch in the pocket and put some lignocaine in. I think that's the best thing. The patient will be comfortable. Yeah.
Yes, I just wanted to get this message through, because that's exactly
Yes.
what we do. I do a subconch or a subtenon and then proceed, and I find that the patients don't complain. That
That's
led
right.
me to do a proper vitrectomy. You know, when there's just a hemorrhage on a subtenon, and I've
That's
done
right.
that, and the patient don't know the difference between that and a block. So a good subtenon, if you have both lignocaine and bupivacaine together, it's a very good combination of anesthesia. So that's the message I wanted to get across. So
Fully
I saw
agree.
your case is wonderful. So in this forum, I just want to say that, you know, anterior-segment surgeons should, you know, try to get familiar with pars plana approach of vitrectomy. If they do, the outcomes are so good, and it's not at all hard to learn. Just a little bit of, if you want to do it, we can all anyway show it to you, and you know, you can come in and learn how to do that. That would really save the day, because there are also other many implications. Like if you have a eye where the intraocular pressure is very, very high, and you have, what do we do normally? We give you an IV mannitol or something to bring the pressures down. Sometimes still the pressure is high. If you think so, as a retina surgeon, I would just put in a cannula, you know, a trocar and a cannula, and open up, let out one little drop of vitreous, and the eye pressure goes down. So you can regulate the pressure like that. That is very helpful for any anterior segment surgeons, like Dr. Ishtiaq knows, and I think he does it regularly. He's a glaucoma surgeon. So for that, I think an anterior segment surgeon should also come in and learn the basic of a pars plana vitrectomy. Thank you. It was a very wonderful thing, and the iris repairs were great, especially the swing technique. I think I've learned that today, the swing technique. The others I've seen before, but the swing technique is one I think I'm going to try if I have a chance next time. I think he's gone, Ashin is gone, but great. And Shamresh, femto second, femto procedure for posterior polar is, I think, the best procedure for that.
I agree.
Safest.
Absolutely.
So it's really great, but it depends on if the patient can afford it or so. Thanks, Ishtiaq. It was a wonderful session.
We want to bring in Professor Sarwar Alam.
Yes.
Sir,
thank you very much.
Question to
every deliberation and every speaker has spoken so nicely, very little to say. I have a question to Dr. Somaresh. Do you evaluate the posterior PC defect present or not? Or if present, what is the size with slit lamp or anti-segment OCT before the surgery?
I think that's a great question, sir. And we use whatever technique necessary. So if the posterior capsule is visible, obviously slit lamp evaluation we do, and we map out the area of the posterior polar area. But we also almost always use the OCT with an anterior segment attachment and just go inwards to look at the posterior capsule status to find if there is those mild stippling that we see behind the posterior capsule, because that gives us a very clear signal that, you know, we have to be extra careful. Sometimes in a mature cataract, we may not be able to see that, and we take the aid of a UBM in that point in time to see the posterior capsule status, to see if there is a pre-existing defect or not. But we follow the protocols as if every polar cataract is going to open up intraoperatively. But it's a very good idea. I think I'm glad you brought that out, sir. It's a very good idea to use whatever means necessary by tilting the slit lamp, by using any oblique illumination, or by using any of the apparatus like OCT, UBM, B-scan to look at a possible chance of an open posterior capsule already in a posterior polar cataract.
And also, you will tell the juniors not to polish at any time after the surgery, because
Absolutely.
you have shown you have shown your video. I have a question to Dr. Lee, that you have said very nicely about the flap mobility and its relationship with the posterior capsular problem. How would you tell the juniors about the snap signs of sudden dilatation of the pupil? How to observe these in difficult or risky cases? How you would emphasize snap sign?
I think the snap sign is usually related to, the over exuberant hydrodissection. So I think as a safety precaution, I tend to very consciously burp the incision before actually doing my hydrodissection. I think a lot of the time when we forget to do that, then you're squirting a big amount of fluid that goes around too quickly without enough time for the viscoelastic to come out. And that's when you get too much pressure and you get the snap or the hydro rupture. So I think for the juniors, I think just make sure that you do not overfill the eye with too much viscoelastic, or once you've completed your CCC, burp a little bit of the viscoelastic out before you actually hydrodissect. I think that's what I would do. So.
Thank you.
Yes.
Dr. Niaz has to leave. I think, thank you, Dr. Niaz, for all the comments and your participation.
Thank you very much. Thank you. It was a wonderful session. All credit goes to Ishtiaq and the faculty. Thank you. Bye.
Thank you, Ishtiaq. Thank you very much. See you again next time. Thank you, everyone. Stay safe.
So, Amoresh, I think if anyone does not have a question, just a last quick question from one of the Indian participants, that is there any simulator in India?
Yeah, so there are. I think most of the good centers. AIMS has one. I think Dr. Rohit Shetty and Narayan Netralaya has a simulator. There is also one floating around. So these people are giving it on rental. I think one can acquire it for a few months and then practice on it. So there are a few simulators. I'm not sure if Dr. Evo's simulator is available, but there is some other version that's available.
Perfect.
Ishtiaq, I have a question for you from Dr. Harun. The question is, which technique is the best technique for is a McConnell or hangback?
McConnell and hangback are quite similar. Hangback means that you don't tighten it totally. If the iris tissue is less, then you keep some little suture so that the pupil is not eccentric. But there is difference between McConnell and swing technique. I think swing technique, saves a lot of time, but performing it is difficult. It's not, maneuvering inside the eye. If it is phakic, it's really hard. So for the beginners, I would say that McConnell, and once you have mastered it, then you can go for swing technique. But what I feel that we should learn all, and then find out which one works best in our hands.
Okay.
I have a question for Ishtiaq. Do you recommend that some surgeons are using endo-illuminator for better visualization of the sutures? Do you recommend that thing for this manipulation?
Yeah, sometimes the cornea, if the cornea is hazy, we can take help. It helps really. It really helps in those sort of cases. But if you can see it without the external illumination holding outside, it's all right. But if required, we should always take help.
One question to Dr. Shamaresh.
Yes, sir.
You're there? Okay. Do you do posterior capsular rhexis in case of polar cataract?
So if we find a pre-existing capsular defect, then we take all the precautions to make sure it does not extend, and then we convert it into a primary posterior capsular rhexis. But if the capsule does not defect during the surgery, we do not touch the capsule because it's very fragile. But in most of the cases where we find either a pre-existing defect or the capsule gives way during the surgery, we take all precautions using pars plana vitrectomy and low parameters and viscoelastic exchange to make sure that we save the margin so that we are able to convert that irregular posterior tear into a regular margin, and therefore try to place a lens in the capsular bag.
Thank you. Thank you.
I have a question. I have a question for Dr. Shamresh regarding the femtosecond assisted posterior polar cataract operation. What is it you show that the three-ring technique for the nucleus fragmentation? This is the best one, or this is the recommended one, or there is any alternative?
No, so we found this in our machine to be the most convenient one because it forms ring, and then we can take it out like disket. But I think any maneuver, all the femto cuts is a vertical wall. It does not cut horizontal. So I think it's fair enough to use any technique, but to use the minimum femto energy so that there is no buildup of hydraulics. And with this it works for us. But I think the chops will work equally good, and I have no reason to believe it won't.
I think you already answered three questions to you by your chatting but I repeat that question for all the attendee. How do you is there any role of viscoprolapse of emulsification in case of cortical matter? Is first question. Second is if the newer surgeon, is it preferable to emulsify the nucleus after take out from the bag and emulsify at the iris level?
Yeah, so I think it's very important to understand that the confidence in a surgeon, particularly a young surgeon, will only come when it's very difficult because the young surgeons get the worst machines to learn on, and as you mature, you get the best machines. It should be the other way around actually.
Right.
Because
exactly.
Once you have that confidence of a good fluidics, you will never bring the nucleus anteriorly because your chamber will be so stable. So I think it's a great idea to understand the dynamics of the machine and use very low parameters. Use low irrigation flow, low aspiration flow rate, because then you will be able to emulsify with a great confidence at the level of the iris, and you will save a lot of the corneas in the long run. So I think iris emulsification at a level of iris plane is any day the only surgery you want to do. You don't want to do an anterior chamber fix.
Okay, thank you. There is a two question for Dr. Lee. One is from Professor Nazrul Islam. What is your recommendation regarding the double rexis in intumescent cataract to avoid the extension of anterior capsule? I can hear it. Dr. Lee?
Lee, unmute.
Sorry. I think I typed the answer earlier about this because, when you do a double rexis, I think you're starting with a smaller rexis and move on slowly if you need to slowly enlarge. I think that's a great safe technique to do if you're starting off, particularly you don't want to suddenly have things run out too quickly. So you start it small. I think you can always go big when you're too small, but when you go big already, then you got to try and salvage the situation. So I think that's definitely the way to do it in the intumescent or white cataract, yes.
Another question to you from Dr. Nahid Kamal. When you use the TA, there is any chance of raised intraocular pressure in postoperative day?
Yeah, actually, I've not had any real trouble with the TA because if it's in the anterior chamber, most of the time when you do anterior vitrectomy and when I do cortical cleanup, I tend to aspirate most of the TA out anyway. And I also mentioned some of the TA when we use it, particularly to visualize vitreous, some of it drops back into the retina, which is fine. So some of it there actually does help to prevent maybe cystoid macular edema and things, but no real problems with the TA, and I don't really dilute it either. So I think it's not really a big problem because you're taking out most of it anyway.
Okay, another question, the last question to you regarding the antechamber IOL. If you are decided to, this is the last procedure, that is that you have to put in antechamber IOL. Which type of antechamber IOL you recommend?
That's the thing. I don't put in any anterior chamber IOLs anymore. But if I had one, and then really, if I had the option to, I won't want to use an angle supported one. So it would be a secondary procedure. I've used a couple of Artisan over the years, and you'll have to order that in. And I think that's quite a good technique to use, and it's not really at the angles and causing the problems. But I've really moved away from anterior chamber IOLs for I think probably more than 5 years now. So I'm just going to do IOL fixation primarily if I need to.
Okay, I can hand over to you. All the questions put by attendee are answered. So, and just my comment to all the faculty is this excellent presentation, and thanks Ishtiaq for involving me in this prestigious webinar. And I now hand over to you for the comment.
Just 1 second. I just wanted to comment before you speak the last slide. This is from your presentation. I think for all the junior doctors, I think Dr. Ishtiaq's presentation teaches us the most important thing is to do a good recording. Because all of you, when you're starting your practices, should invest in a good recording setup. All these words, they take effort. It takes a long time to learn. But if you document it, the knowledge can be shared on platforms like this. And it's, I mean, Dr. Ishaq, I loved your videos. They were so crisp. And that is, I think, the one take-home message that, we don't discuss, but we should learn that more often than not as to how to record a great surgical video.
Yeah.
Thank you, Samaresh. I think we are very grateful to you because all the things that we use here, we take your advice before buying anything. He is a master in this thing. And I would recommend that if any of the hospitals need any help or assistance regarding this thing, is, just drop a mail to Samaresh.
Anytime.
So I think we are at the end of the session. I thank again all the speakers and our panelists, Dr. Mahbub Rahman Chaudhary, Dr. Abdul Rakib Tushar, Professor Sarwar Alam, and Dr. Samaresh, Dr. Lee, and I invite all the participants to join next Friday, same time. We'll have a webinar on small people management, and there are going to be some great speakers, Dr. Boris Melugin, Suven Bhattacharya, and it's going to be Dr. Tanapong and Ehud Asiya from Israel. And we'll have Samaresh and Dr. Lee and Professor Nozrul and Dr. Khaya Chaudhary as panelists. So with this, we want to end the webinar for today. Thank you again, everyone, for joining.
Thank you.
Thank you.
very
Thank
much.
you.
Thank you. Bye-bye.
Thank you.
Bye-bye. Thank you.
Bye.